Hi everyone, and welcome to our module on sleep apnea. So apnea means the cessation of breathing, and therefore sleep apnea obviously means the cessation of breathing that occurs during sleep. And there are various definitions, but usually to be considered an episode of sleep apnea, it has to last longer than 10 seconds without a breath. And most patients who suffer from sleep apnea have multiple episodes that occur per night. Because the episodes of apnea happen at night, the patient usually isn't aware of them, so what brings them to the attention of a physician is usually unrestful sleep or daytime somnolence. These patients are being woken up by the episodes of apnea, but they're not waking up enough to regain consciousness. The result is that throughout the night they're having episodes where they wake up briefly, sometimes up to several times per hour, and they get a really lousy night's sleep. Sometimes sleep apnea patients can be so tired during the day that they fall asleep while driving. Another classic symptom of sleep apnea is loud snoring. This is often reported by the patient's partner who says they're snoring very loudly at night, and this is because they're having poor flow through their airway, and this makes the snoring sound. There are two types of sleep apnea. The first type is called central sleep apnea, and this is where the patient has no effort to take a breath during sleep. This is the rarer type of sleep apnea. What's much more common is what's called obstructive sleep apnea, often called OSA, and this is where there's decreased airflow despite an effort to breathe by the patient. We'll talk more about both of these in just a second. Let's talk about central sleep apnea first. So one scenario where this occurs is in patients who have marginal ventilation status when they're awake. So these patients are hypoventilating even when they're awake. Then when they fall asleep and their respiratory status declines slightly, which is normal with sleep, they develop periods of apnea. And this can happen to people who have central nervous system disease like encephalitis, where the brain function is depressed, patients with neuromuscular disease like polio or ALS, some patients who have a severe bend in their spine like kyphoscoliosis, and also some patients on heavy dosages of narcotics. And just remember, these patients are hypoventilating all the time, and then when they fall asleep, their ventilation rate gets so low that they have periods of apnea. The other scenario where central sleep apnea occurs is something called Cheyne-Stokes breathing, and this is a cyclical breathing pattern that happens when patients have a delayed detection and response to changes in carbon dioxide level. This is very common in patients with heart failure and stroke, and always remember heart failure and stroke patients are the type of patients who exhibit Cheyne-Stokes breathing. So let's look down here on the left with a patient who has normal breathing. So they're having airflow go in and out in a nice normal cyclical pattern in their lungs. Now let's look on the right at a patient with Cheyne-Stokes breathing. They are rapidly bringing air in and out to their lungs, and what this does is this lowers the CO2 level. Their brain then over-responds to that and shuts down breathing for a period of time, and they become apneic. Then their CO2 level starts to rise, and they go back and have another rapid breathing session. So this is a pattern that happens because the brain is overshooting in its detection to carbon dioxide. It's hyperventilating and then going apneic in periods back and forth, causing the Cheyne-Stokes breathing pattern. Now let's talk about obstructive sleep apnea, which is far more common than central sleep apnea, and this is recurrent soft tissue collapse in the pharynx. If you've ever looked in the back of the throat of your patients, you know that there is a small opening there where air can pass down into the trachea. When patients become obese, that opening gets smaller and smaller, and if they're severely obese, that opening can actually close during sleep, and this will cause periods of apnea. So if you remember this as fatty tissue closing off the pharynx, then it's easy to remember that the strongest risk factor for obstructive sleep apnea is obesity. So why is sleep apnea bad? Well, one reason is because it can cause daytime somnolence. Patients with sleep apnea can be very tired during the day, and in fact, they can get so exhausted that they fall asleep while driving, which is obviously dangerous. But the other reason sleep apnea is bad is because it causes low levels of oxygen at night, and this is going to ramp up the sympathetic nervous system and put patients at risk for cardiovascular complications. So what are those? Well, the first one is hypertension, and sleep apnea is commonly associated with difficult to manage hypertension. Another complication of sleep apnea is pulmonary hypertension. All that low oxygen level can lead to pulmonary vasoconstriction. This can cause high pressure in the lungs. The intermittent low levels of oxygen can lead to arrhythmias in the heart, and it can also cause sudden death. So something that rarely happens to sleep apnea patients is they die in their sleep, and it's because they had a prolonged period of apnea and they were deprived of oxygen and they went into a ventricular arrhythmia and had a sudden cardiac arrest. Another thing you should know about sleep apnea, because they like to ask about it on the boards, is that the low oxygen can be a trigger for erythropoiesis. So the chronic hypoxia can stimulate EPO release, and patients who have sleep apnea can get an increase in their hematocrit. It's usually mild. They usually don't have a severe polycythemia, but they do see some increase in the red blood cell count because of the chronic hypoxia during sleep. So what do you do when you meet a patient who's overweight and complains of daytime somnolence and you think they might have sleep apnea? What you do is order something called a sleep study, and the formal word for a sleep study is a polysomnogram. And this is where the patient sleeps in a monitored setting. They'll have their EEG and eye movements monitored so you can determine when they go into REM sleep. They'll also have their oxygen level, heart rate, and respiratory rate monitored. And at the end of a sleep study, you can determine how many apnea episodes the patient is having per night. So how do you treat sleep apnea? Well, weight loss is a great way to treat the condition. If patients can lose some of that fatty tissue in the back of their pharynx, then it will stop closing off when they sleep at night. The problem with weight loss is it takes time, and some patients can't do it anyway. And in addition, it's not the best option when patients are exhausted from sleep apnea. They need something to revitalize them and get them to have a good night's sleep so they can then start exercising and lose weight. CPAP, which is continuous positive airway pressure, is first-line therapy for symptomatic patients. I'll show you some pictures of this in a minute. This is where you apply a mask to the face of patients at night for when they sleep to keep the airway from closing. And then finally, patients who have severe disease sometimes have surgery to essentially cut away some of that fatty tissue in the pharynx so that it won't close off at night while they're sleeping. These are some pictures of the different types of continuous positive airway pressure treatments that patients can use. So one is a nasal insert like I've shown here. There's also a nasal mask, and there's a full face mask. Patients have to connect this to a machine at their bedside, and then they have to sleep with it. And you can imagine it's very uncomfortable to sleep with one of these apparatuses on your face, and many patients are non-compliant. They're just not able to sleep with it on. So CPAP therapy, although it works in theory, for many patients it doesn't work in practice. And that concludes our module on sleep apnea.